انا عندي حاله مدوخاني بقالها 3 شهور، عندها نوزيا وعندها فوميتنج. فقلت له خلاص يا باشا انت تيجي تقول لنا الحاله دي وخلاص. ودي كانت القصه بتاعت المحاضره. قبل ما يتكلم دكتور حسام، برضو شركه زيتا عامله جايزه عشان الناس بقى اللي سهرانه كده، اير بودز هتتوزع في اخر السيشن ان شاء الله. شكرا. فهيبقى سؤال طبعا من المحاضرات. شكرا جزيلا. اتفضل يا بيه.
شكرا دكتور محمد، شكرا على دعوتي وشكرا على اختيار الموضوع. انا لما هديت شويه وقعدت افكر في الموضوع لقيت ان انت عندك حق. يعني going back to basics, going back to ال clinical practice اللي بنشوفه ديلي في عياداتنا، فده كان الابروتش بتاعي الحقيقه اكتر من انه يكون scientific approach بديفينيشنز كتيره قوي بالجوريثمز كتيره قوي. those are my references. الكومبلكس physiology of vomiting ونوزيا مهم ان احنا نعرفه الحقيقه، لكن انا I will spotlight من غير much details. احنا عندنا 4 triggers of vomiting. حاجه بتريجر الفوميتنج سنتر في الميدالا of the brain، وحاجه بتريجر الكيمو ريسبتور تريجر زون برضو في الميدالا of the brain، وحاجه بتريجر الفيستيبولر كومبارتمنت، وحاجات كتير sensory higher sensory زي emotions وستريس دول بيتريجر الفوميتنج سنترز دايركتلي. فدول الاربع حاجات اللي بيتريجر الفوميتنج او اللي بيستارت فوميتنج. طبعا الحاجات دي كلها working through receptors. الفوميتنج سنتر through dopamine receptor، السي تي زد through serotonin receptors، فالفيستيبولر ثرو هيستامين ريسبتورز. فلما نقدر نعرف كل الريسبتورز اللي بتشتغل وبتدينا في الاخر فوميتنج، ده بيبقى ريفلكتد على الدايجنوزز بتاعنا، وريفلكتد كمان على التايبس اوف تريتمنت اللي هختارها في ايتش كيس. مفيش one size fits all في التريتمنت اوف ذا فوميتنج. الابروتش زي ما معظم الابروتش في القضايا اللي to do with الارت اوف ميديسن اكتر من الساينس اوف ميديسن، I have to consider الحاجات الموست سيريس، يعني exclude emergency and urgency الاول. وده عادة بيبقى obvious، وبالgood history taking we can understand if we are dealing with an emergent or an urgent case، زي surgical causes في IO وفي perforated viscous، زي الcerebral causes سواء hemorrhagic أو space occupying lesions، أو cardiovascular causes زي MI. MI كتير بيجوا الحقيقة بيشتكوا من بس epigastric pain و vomiting or nausea. الحاجات الموست كومن اللي ما ينفعش او تبقى عيب انها تعدي عليا وما اشوفهاش، ان انا suspect infectious causes، اهمها الجي اي والجاستروانترايتس and so on، pregnancy of course، toxic causes and psychiatric motor ones. and then الموست uncommon والموست rare اللي دايما تفكيري بيجي فيهم late شويه. ممكن اقسم الكوزز لاكيوت وكرونيك ونحط عناوين كتيره تحتيهم، لكن التقسيمه البيتر از باي سيستم وديفرنشال دايجنوزز، الحاجات الموست كومن والموست انكومن في each system starting by the cerebral nervous system because it's one of the most important causes of chronic nausea and vomiting. الحاجات الكومن زي البناين بوزيشنال فيرتايجو، زي الميجرين، زي الموشن سيكنس. الحاجات اللي less common زي cerebrovascular events او closed head injury، hydrocephalus. بعدين الجاستروانتستاينال كوزز برضو الكومن والانكومن. amongst the most common الابندسايتس. انا راجل باطني لكن ممكن يجي لي عيان عنده appendicitis، ما ينفعش اقول له احنا مش في ER emergency room اقول له شوف نايب الجراحه هيقول ايه وبعدين نرجع لي. so I should be able to suspect and diagnose even surgical conditions زي الكوليسيستايتس، زي الجاسترايتس او الجيرد او الجاستروباريسيس اتسترا. وطبعا a wide array of other causes like infections, metabolic causes, medications, toxins and others. So one of the very good words I use in medicine is pattern. If you are able to recognize pattern, you are able to diagnose. واللي بيحصل الحقيقه ان recognizing pattern مع integration of information بيحل لي 75% of cases من من وانا قاعد على الكرسي بتاعي ورا المكتب، لسه حتى ما شفتش العيان. الجود هيستوري تيكينج. فالباترن از فيري امبورتنت في الفوميتنج، لانه سبيشال باترن ممكن يشاور على الدايجنوزز. زي مثلا لو اكيوت اونست ده ماشي اكتر مع كوليسيستايتس، جاستروانترايتس، ميديكيشن ريليتد، او ان يكون associated with diarrhea وهيديك وميالجياز ده ماشي اكتر مع فيرال جاستروانترايتس، او ان يكون bilious vomiting والbilious vomiting is an indication of a small bowel obstruction، او continuous vomiting. في ناس بيجي in attacks of continuous vomitings ودول الناس اللي هم psychologically disturbed او بيبقى عندهم namely conversion disorders. delayed vomiting في gastric obstruction، الفيكولنت vomiting على مستوى intestinal obstruction على مستوى الكولون. And so on, many patterns زي projectile vomiting مثلا، برضو intracranial disorders with space occupying lesions. So it's very important to recognize pattern in a case presenting to you with vomiting or nausea. لكن يبقى 3 entities مهمين من الروم كرايتيريا الحقيقة، وهم دول اللي هذكرهم باي نيم لانه محيرين في الدايجنوزس بتاعهم وبقينا نشوفهم مور كومن ذان بيفور، اللي هو الدايجنوستيك كرايتيريا فور chronic nausea vomiting syndrome. And they must include all of the following, which are: number 1 bothersome، يعني حاجة بتضايق، حاجة بتعوق الشخص عن عمله والديلي اكتيفيتيز بتاعته، severe enough to impact on usual activities. Nausea occurring at least 1 day per week and or 1 or more vomiting episodes per week. ويكون معاها self-induced vomiting, eating disorders, regurgitation or rumination should be excluded. And there should be no evidence of organic, systemic or metabolic disease likely to explain. يعني النوزيا والفوميتنج ما لقينا لهمش cause واضح. ساعتها اقدر احط الترم of chronic nausea vomiting syndrome and those criteria fulfilled for the last 3 months within symptom onset at least 6 months prior to diagnosis. الحاجة الثانية المهمة الحقيقة is the cyclic vomiting syndrome. وبرضو الروم criteria was very clear about it. It is stereotypical episodes of vomiting regarding onset اللي هي بتبقى acute and duration اللي بيبقى less than 1 week. At least 3 discrete episodes in the prior year and 2 episodes in the past 6 months occurring at least 1 week apart, and absence of vomiting between episodes but other milder symptoms can be present between the cycles. Something pretty much like the FMF. طبعا supportive remark إن يكون في family history of migraine or headaches. This is a supportive remark for the diagnosis of cyclic vomiting syndrome. And lastly, the cannabinoid hyperemesis syndrome, which must include all of the following: the stereotypical episodic vomiting resembling cyclic vomiting syndrome in terms of onset, duration, and frequency, presentation after prolonged use of cannabis, relief of vomiting episodes by sustained cessation of cannabis use, and the supporting remarks, of course, this may be associated with pathological bathing behavior, prolonged hot baths or showers. The clinical evaluation for a case of nausea and vomiting when you're confronted with one is basically 2 categories. Number 1, assessment of present physical status of the patient عشان نعرف الستاتس دلوقتي of the patient عامله ازاي. النوزيا والفوميتنج قد ايه مأثره، لو عنده poor nutritional status, if he is dehydrated in any way أو وصل لمرحلة إن عنده electrolyte imbalance, this should catch my attention first things first. And of course the assessment of the potential underlying cause. وهنا أهمية good history taking good clinical evaluation. Full history is indispensable in diagnosis and management of cases of nausea and vomiting, especially recognizing the alarming signs, and those are age older than 55, unintended weight loss, progressive dysphagia, GI bleeding, altered mental status, abdominal pain, feculent vomitus, focal neurologic deficit, and family history of GI malignancies. All those are very important alarming signs to look for. Having clinically evaluated the patient and tried to rule out any alarming signs, now I can go to the algorithm of management of clinical evaluation of those patients. Duration of symptoms less than 1 week, I will have to see if it is acute nausea and vomiting, and if there are obvious causes. If there are, we treat accordingly. No obvious causes, I have to exclude any alarming signs. If I have alarming signs, I go through a thorough examination and investigations for the patients. If I don't have an alarming obvious sign, I can suspect a diagnosis in cases of acute symptoms, like provide education, reassurance, and supportive case, and in chronic cases, gastric emptying study if gastroparesis is suspected for somehow. And likewise, if the durations are more than 1 month, this is a chronic nausea and vomiting, and I should look for the obvious causes. If I find them, I treat accordingly. If I don't find them, again, I try to elicit some of the alarming signs and manage accordingly. How about the approach to management? It's a combination of all those skills, which are the very important skills to practice medicine. I always say to myself, and this is one of my favorite sayings, medicine is science and art. The science of medicine we learn, and the art of medicine we do and we practice. So this is one of the arts of medicine, is integration, just like recognizing pattern. It's not all about antiemetics. We have a lot of things to do. Resuscitation for the patient, like electrolytes replenishment, IV fluids if the patient was dehydrated, bowel rest, nutritional support, and then treatment of the symptoms. Prokinetics are very important. Antiemetics, of course, are very important. We'll talk about them in some detail, but also we have prokinetics and we have analgesics, and then treatment of the cause, whether medical treatment, like for instance PPIs or PCABs in peptic ulcer disease, or surgical, or even gastric electrical stimuli in case of gastroparesis. The problem with antiemetic drugs is that there are so many and they work on different levels. So we have to have a clear understanding of our tools. We have to know what we are using, how we use it, and when to use it. Antiemetic drugs are classes, and those classes I use according to the suspicion of diagnosis. Where is it starting? Do I have a problem in the vestibular system? Therefore, I will use antihistaminics. Do I have a problem in the CTZ zone? Therefore, I use anti-serotonin ones. Do we have a problem in the stomach? Chemotherapy, surgery, we use gastric prokinetic agents, and so on. So please, you have to have a good understanding of the antiemetic classes, when to use them and how. To simplify a little bit, selection of antiemetics by clinical situation is feasible. Like for migraine, we use metoclopramide or prochlorpromazine. For vestibular nausea from the ear, we use antihistaminics and anticholinergics. For pregnancy, ginger and vitamin B6. For gastroenteritis, first-line agents like dopamine antagonists, and second-line agents like the serotonin antagonists. And for post-operative nausea and vomiting, we can use serotonin antagonist and dexamethasone. Again, simplifying the cause and the treatment of the cause. Benign postural hypertension, you can use the meclizine, and benign self-limited with no alarms, you can use the ginger or the oral rehydrations alone. Gastroenteritis, ondansetron, along with, of course, treatment of the cause. And gastroesophageal reflux, antihistaminics, gastroparesis, erythromycin, and metoclopramide. So we have to, the basic message is we have to understand when to use what. And this is my take-home message. Please remember the mindset, the integration, the pattern, collectively known as the art of medicine. Thank you very much.
شكرا جزيلا دكتور حسام. الحقيقه المحاضره تشالنجينج بس